Dr. Jenny Alexopulos. She will be presenting a CLER overview. Our program is underwritten by an educational grant through OSU Medical Center, Graduate Medical Education. A disclosure statement has been signed as on file in the Graduate Medical Education Office. Dr. Alexopulos is a graduate of the Kirksville College of Osteopathic Medicine at Kirksville, Missouri. She completed her rotating internship and family medicine residency here at OSU and has been actively involved in the graduate medical education during her professional career. Dr. Alexopulos is board certified by the American Osteopathic Board of Family Physicians. She is the statewide director of the Clinical Learning Environment Review, representing the Oklahoma State University Center for Health Sciences and the Osteopathic Medical Education Consortium of Oklahoma. She serves as the OSU Medical Center Family Medicine Residency Site Director and is a professor of family medicine with the Oklahoma State University College of Osteopathic Medicine. Dr. Alexopulos serves as a member of the Oklahoma State Board of Health, representing Ottawa, Delaware, Craig, Mays, Nowata, Rogers, Washington, Tulsa, Pawnee, and Osage counties. Please give everyone a warm welcome to Dr. Alexopulos.
Thank you, Dr. Shruji. Thank you for that kind introduction. So today we're going to talk about our clinical learning environment review. And essentially, since we are an ACGME accredited sponsoring institution, as well as all of our programs are ACGME accredited, ACGME requires that we have a visit by a CLER site team. And that site team will come to visit us every 18 to 24 months. Of course, because of the pandemic, we actually were slated to have a visit last year. So that has been deferred, and there's a possibility that we will have a site visit this year virtually, or perhaps next year in person. So I wanted to take this opportunity to kind of share where we are in our CLER journey. Also, before we start, I just wanted to let everyone know I have no conflicts of interest or disclosures. What is CLER? It really is an ACGME's assessment of how we prepare our residents and fellows to engage in the quality improvement and patient safety initiatives of our institution. So alongside your medical education, we want to make sure that you are well-versed and prepared to go out into the world after graduation, so that you can be a contributing member of the quality improvement and patient safety initiatives of those institutions that you represent. And again, the goals of CLER are to really support these national efforts that address quality. And as you know, we work in a very dynamic and complex healthcare system, both inpatient and outpatient. And so we want to do what we can to minimize and decrease the poor outcomes in some cases, and we want to also have an effect on the reduction on healthcare disparities. There are 6 goals or 6 focus areas under CLER, and here they are. So central to all this and foundational to these focus areas is of course professionalism, how we conduct ourselves in our interpersonal relationships, with our healthcare team, with our peers, with our patients, their families. How we conduct ourselves has a significant bearing on one's reputation moving forward. And so the other areas are, of course, patient safety, healthcare quality, and under healthcare quality, we have the disparities, healthcare disparities that we address. Under the clinical learning environment, there's 3 areas that we focus on in terms of expectations and opportunities, and they are duty hours, fatigue management, so how we manage fatigue when we are tired and stressed. We have opportunities to mitigate those effects on our residents and fellows, and indirectly, of course, on our patients. And when we have wellness opportunities, so many of our programs do have wellness initiatives and champions. Transitions of care, this was one of the original six focus areas. And this really is development of a standardized tool for handing off patient information from day team to night team, night team to day team. This has most recently transitioned into a focus area known as teaming, and we'll be talking about that here shortly. That is a relatively new focus area, and so there's a lot of initiatives going on across the country at multiple academic institutions. And then supervision. We are very interested in knowing what your perspective is on the adequacy of your supervision. Do you feel that you are over-supervised or under-supervised or adequately supervised? So we want to know how well you feel that you are prepared to go out and practice autonomously. So when those site visitors come, they'll want to know where we are in this journey of integrating our residents and our fellows in the quality improvement, patient safety initiatives at the hospital. And I will say historically, the GME and hospital administration along these areas have been largely siloed. I think over the last 7 years with CLER and other ACG initiatives, we have come a little bit further along in this integration. So let's talk about what we're doing here at OSUNC. We have these 6 focus areas that are chaired by physicians in a subcommittee. There are subcommittee chairs, and here's our team. So Dr. Erin Lane is the chair of patient safety. Dr. Crystal David is our chair of healthcare quality. Dr. Glenda Tiller is our chair of teaming. Dr. Adam Bradley, our chair of supervision. Dr. Chris Thurman is our chair of professionalism, and I also chair well-being. And CLER is really those site visitors are going to also want to know that you know what the national patient safety goals are. And these really don't change significantly from year to year, but these are the 2021 National Patient Safety Goals. And it revolves around accurately identifying a patient to minimize any errors, improving staff communication, safety around medication administration, reducing harm from with regard to these clinical alarm systems, reducing the risk of healthcare-associated infections, which we see, and identifying patient safety risks within the hospital. So those are just a few, but please become familiar with these because you most likely will be asked about these national patient safety goals. And here's a kind of more specific drilled down safety goals about two forms of patient identification, reporting these critical results on a timely basis, how it comes into the electronic record and your response, labeling medications, reducing harm from anticoagulation therapy, preventing wrong patient, wrong site, and wrong procedures. These are also Joint Commission. These come out of Joint Commission in terms of these patient safety goals. So patient safety and how we've approached patient safety here at OSUMC, we have a number of modalities. Most of you may know that we do have an incident reporting system known as Verge. And this is a risk management tool that the hospital uses to gather information on adverse incidents that have occurred anywhere in the hospital. And so we'll talk about that here shortly. We have had these safety event team meetings, which most recently have been more of a safety huddle. And that patient safety opportunity for resident and faculty involvement is evolving. So we'll have more information on that to come. Mortality and morbidity conferences. Prior to the pandemic, we had a very robust multidisciplinary mortality and morbidity conference in our auditorium. Since we haven't been able to aggregate in those large numbers to date, each of our departments and residencies should be conducting their own departmental mortality and morbidity conferences. And then health streams training. I know that we have all gone through health streams training on an annual basis. There are a number of modules that are focusing on patient safety. So that is also one of the ways we train our residents and fellows and faculty in patient safety. Many of the programs do have team care interdisciplinary rounds. So you may have, for example, PharmD or other disciplines rounding with you during the course of your inpatient rounds. And in some cases, you may have a little bit more expansive representation from other disciplines in your day-to-day team care rounds. And then we also have a clinical document improvement program, CDI. Faculty are well versed in this CDI program, and we often get information to quantify or clarify diagnoses for coding purposes. So how do I enter a risk management? We have a Ozone is our intranet for OSUMC. There's a lot of information there on a number of departments and activities. And if you go into Ozone and you click under departments, you'll have a drop-down box. And if you go down to quality management, there'll be another drop-down box, and you'll see this risk management incident reporting. If you click on that, it'll open up this box right here, and I'm going to expand that for you in this next slide. You will see a number of categories that where incidents can be reported. So perhaps you might have had an airway or anesthesia incident, adverse incident. You'd go ahead and click on this. It'll bring you through a number of boxes. What's great about this tool is it does not take long to actually enter an incident, possibly 2 to 5 minutes. That goes to our risk management and quality department. And these types of incidents are trended and tracked. And the goal here is to really look for system process failures or system process opportunities for improvement. And so you can see of the various types of incidents. You may have a patient that has developed a pulmonary embolus in the hospital or a deep vein thrombosis. There could be device or equipment failures. Patients, family members, visitors may fall. So there are slip and fall. incidents that can be reported, laboratory issues, radiology issues. So we really do encourage our residents and fellows to be on the lookout for these adverse events and know that they have a personal opportunity to place these incidents in the reporting system so that they can be investigated. So why is CLER interested in this? Of course, it is a patient safety measure. They would like to know when they come here, they're going to ask, how many incidents are reported each year in your institution? And then how many of these are adverse events, so where something has gone wrong? And the majority of these across the country that are reported by staff and residents and faculty are adverse. But what we really need to get to is really identifying those areas where there are near misses or close calls, and how we enter those or how we recognize those as potential issues are important. And of course, the unsafe conditions. Reporting an unsafe condition that has the potential to do harm to a patient or staff or visitor is important. So they want to know the percentage of these incidents that are reported by staff, how many are reported by faculty, and percentage reported by residents. They really want to know this number. And what we're looking for internally is improvement year over year in the percentage of these incidents actually reported by our residents and fellows. So what is an adverse event? It's typically an injury, and it's rather than being caused by the underlying disease, it's caused by medical management, okay? It can prolong the hospitalization, or it can produce some kind of disability at the time of discharge, or likely both. Adverse events, by definition, are categorized into preventable and non-preventable. Those preventable adverse events are avoidable by any means currently available, okay? Those preventable adverse events are defined as care that has fallen below the standard of care expected for the community. So a near miss is essentially a close call or a good catch. Okay, so you might hear all of these terms when those site visitors come, and just so this is an event that might have resulted in harm, but the problem did not reach the patient. Okay, because typically in these cases there's a timely intervention. Perhaps the patient was going down for a BKA, and somewhere along the line, the incorrect limb was targeted for the intervention, but somebody caught this error on the way down. Okay, so that's an example of a near miss or a close call, and a good catch. So an unsafe condition is any circumstance that increases the probability of a patient safety event. So, and it could be anywhere in the environment. It may be medically related. It may be, an issue where there may be a spillage of bodily fluids in a patient room or down a hallway or coffee. All these can lead to slip and falls and patient safety events as well. And typically these unsafe conditions is not identifiable to a patient. So our quality improvement programs, annually we have a quality improvement patient safety poster symposium. This is annually in May. We've had 4 of these in the last few years, and each year the participation by our programs internally and outside of outside OSUMC have really taken off. We've had increased participation in an interdisciplinary way as well by involvement of other disciplines in these quality improvement posters. So you'll hear more of that within your own programs, and our residents can work in groups together along with choosing a patient safety initiative, quality improvement initiative that is centered around their discipline. So we look forward to that. And we put out a quality improvement handbook. It is a patient safety project handbook. This is a step-by-step guide in preparing for a poster presentation. Okay, it takes you through how to choose your initial topic or patient safety issue, how to work through that over the course of several months, right up to publication of your poster and presentation. So you'll have more of that to come. And Dr. Crystal David is our chair, and she'll be also giving a presentation later, I think next month, on how to develop a topic and a project. So looking forward to that. Your quality projects, along with your research projects, should be captured as scholarly activity in new innovations. And as you know, new innovations is your resident management data system where all of your resident activity is captured. So please know that your quality projects should be entered there as well. I'm not certain if our site visitors are going to actually request to see this in new innovation, but I think it would be a good idea to be prepared for that. The hospital puts out a monthly QI newsletter as well. We've had some interruption in those newsletters over the course of the pandemic, but my understanding is that they will be restarted on a regular basis. And of course, disaster preparedness is in health streams. We have cultural competency training as well in health streams. So when our site visitors come, they will ask our residents and fellows and anyone that's participating on that site visit if our residents know what this hospital's quality projects and priorities are. And so I'd like for you to just kind of remember these. These are things that we deal with as we care for our patients in our hospital. CLOPSI, so that is central line associated bloodstream infections. CAUTI are catheter associated UTIs and how we reduce those. We have a focused effort around improving care for those patients that are status post CABG. We have a restraint reduction program. We have a fall reduction program, and of course a fall response team that responds when patients do fall. And we have SWAT. SWAT is for skin wound assessment team. So the SWAT team in concert with our wound team and our surgical teams really assist in reducing the incidence of these pressure injuries for those patients that have long-term stays and are bedbound. And sepsis, of course, we all see patients with sepsis, and diagnosing and improving the care and the outcome for these patients is important. And then we have a program known as Up Mobility, where we work to increase the mobility of our patients that have comorbid conditions that might keep them down and in bed. So a lot of work around that. So please know what these are, and it is very likely that our site visitors will ask us, ask our residents if they know what the quality improvement priorities are of this hospital. And each hospital has some of these, but they may have other priorities based on their situations. Now, supervision. Supervision is another focus area under CLER. And again, we want to know that, that you are being adequately supervised in your training, that you have not been exposed to conducting any procedures or carrying out any treatment plans without the support that you need. So we have this resident privileging audit that we do. And your program directors twice a year will go into your privileging audit and privileging record in new innovations. And they will look at all of your procedures and determine what level of competency and supervision you will require in order to do a procedure. And this is going to be really important for our nursing staff, because our nursing staff may not know all of the residents and their competencies to provide procedures at the bedside with or without direct supervision. Now, we're favored here at OSUMC because we have a relatively stable nursing staff, and they get quite familiar with our residents across all programs. So they have a pretty good idea of who can do what. And if there are any questions, they can call the attending. That happens very rarely here, luckily. However, we must demonstrate to our site visitors that the nursing do have access to this. Our site visitors also want to know that you, the resident, and the fellows know what your privileging is as it pertains to each of those procedures. So I would recommend that each of our residents go into new innovations and look their privileging up so that they know what their capabilities are. With regard to the resident survey, every year ACGME sends you a resident survey and asks you a number of questions about your training. There are 2 questions directed at your supervision with regard to your supervision. So they want to know, are you over supervised? Are you under supervised? Are you supervised just right? Are you adequately supervised? This information is used in a de-identified fashion to let us know as trainers where we need to make some improvements in your supervision, okay? So we use that data to guide improvement in your training environment. When you graduate, there is an exit survey that you'll complete. And there is a question that asks about how you feel about your training and whether you feel comfortable going into autonomous practice without direct supervision. And so you'll see some responses, yes, somewhat, or no. So we also look at that data in a de-identified fashion to address any changes that moving forward. Our patients receive a patient orientation packet, and our patients really need to know what it's like to be cared for in an academic setting. So not only are there staff that work with our patients, but there are medical students and residents and fellows and attendings and consultants, and their medical students and residents and fellows and attendings. And so we put together an addition to the hospital's orientation packet to let them know, let our patients know that there is supervision by an attending, by senior residents in this arena of academic in an academic health center. So this is provided both in English and Spanish. And we are looking at these packets on an annual basis to see if we need to make any changes with regard to our patient communication. And then lastly, under supervision, we have a beautiful simulation center over at the over across the river at the medical school, we have the opportunity to do some interdisciplinary simulation training where attendings and senior residents and faculty can supervise simulation based on your discipline. And so we have used this simulation opportunity for several years now, and we encourage all the programs to reach out and have these discussions in your didactics or with your program director and faculty, and develop some simulations scenarios that you can use our simulation center to do this. CLER really does emphasize the value of interdisciplinary simulation. So you may want to consider having anesthesia, respiratory therapy, nursing, physical therapy involved in some of your simulations, and that's kind of one of our goals as well. So this is ever evolving, and we're excited to see this come to us as an opportunity. So let's talk about what the levels of supervision are. ACGME has some very specific definitions, and there are about 4 of them that are used, 4 or 5. Under direct supervision, in this case, the supervising physician or the senior resident is physically present with the resident and the patient. So they're there for the encounter together. Under indirect supervision, there are 2 categories. One where there is direct supervision that's immediately available, and one where there's direct supervision available. So there's a subtle difference in terminology, but a big difference in terms of the supervision. So in this case, with direct supervision immediately available, the supervising physician or the senior resident is physically within the hospital, okay? So they're there, they're immediately available to provide that direct supervision. They may be in another area of the hospital, but they're available immediately within the facility. The other category is where the direct supervision is available. And in this case, the attending may not be physically at the site, but maybe at another hospital. It may be overnight, they may be at home, but they are available telephonically or by some kind of electronic modality, either core text or text. We try not to use or text messaging, so we have now core text. So please, if it has to do with patient care, please use our core text within our system that is protected information. Oversight. This is a category which is somewhat unique, and it's and there are some programs, some of the surgical and procedural programs that use oversight or conditional independence as a category. And in this case, these residents or fellows really are at that upper level of mastery. They tend to be the seniors. They have a track record of having excellent competency in these procedures and encounters. And usually the feedback that is done in oversight is the attending provides feedback after the care is delivered. It is what we call a progressive authority and responsibility. So this may be something that your program directors will will use. So if you see that in your resident privileging area and new innovations, know that that's what this is. Again, our nurses must have access to the resident privileging logs. So you know they will have their own, they do have their own username and password, and it is universal to all the nurses. They will not have any access to any other part of your record. It goes directly to the resident privileging area, and this is how they access that record. Now, again, it doesn't happen very frequently, but the site visitors may ask any of our nurses to go in and look up a resident. So transitions of care, as I said previously, we do have, most of the programs do have a standardized handoff tool. The one that we use here most commonly is the IPASS, and the IPASS has nomenclature that defines a resident as being a stable patient, unstable patient, or otherwise known as a watcher. So stable, unstable, or watcher. And this is has a lot of patient data for the night resident or day team. The handoffs are critical in that the information handed off is pertinent to what might occur, what is occurring, and what to watch for. So these are computerized handoffs. Some of the programs will print off that computerized handoff in preparation for their handoff from day team to night team, night team to day team. And then our faculty will periodically be observing your handoffs, and they don't have to be there on a daily basis, but periodically it's important that our faculty are there to observe the process and give some feedback in terms of the process itself. And then this is great communication to the program directors and the faculty that our residents have a pretty good feel for the severity of illness and the potential for instability overnight or during the day, and really increases the quality of care and patient safety. This is the assessment tool that our faculty use when they come to witness, to observe your handoff. And this is filled out and given to your program director so that if there are any questions with regard to the site visitors, that this is being done, they can demonstrate that these have occurred. Teaming, okay, so this is the most recent focus area, and again, it stems out of the transitions of care initial focus area. And this really places some emphasis on how we interact around the patient in an interdisciplinary or an interprofessional manner. So do we involve other disciplines in the care of that patient, and how do we do that? Each program will most likely have a different approach and a different process and a different protocol. And we want to capture all that. Moving forward, this is a dynamic process. We'll have opportunities to do this and develop this over time. The clinical learning environment, duty hours, you all know we have a duty hours policy. All trainees are required to log their duty hours and have 100% compliance. These are monitored on a monthly basis by your program director, and then that data, that information is sent to our DIO, who is Dr. Gary Slick, and we at the GME committee will review these for compliance. There are faculty and resident presentations on fatigue and fatigue mitigation. We'll have those in a grand round setting. Likely you'll have them in your didactic programs. As you all know, you've all seen our quiet rooms that we have, these call rooms for rest. They are in our GME wing. Later this fall, we are going to have send out a burnout survey. So CLER and ACGME are very interested in assessing the effects of burnout on our entire clinical learning environment. So what does that mean? That means what is the effect, what is the measurement of burnout, and what is the effect of burnout on our residents, our fellows, our staff, our faculty, our hospital staff, our nurses? What is the effect of burnout? And certainly we are concerned about the effects of that burnout on the care of our patients. So that burnout survey will be coming out. It's very short, takes about 5 to 10 minutes to fill out, but it gives us a lot of opportunity to assess burnout in our CLER and our CLE, our clinical learning environment. We have resident gym enhancements, so please avail yourself to that opportunity. We also have a gym fitness room over at the college. Each of our programs do have a faculty and resident wellness champions. So under well-being, we have a wellness response algorithm, which I'll show you here in a moment. We have 2 presentations per year on grand rounds on well-being. There is a wellness flip book, and you can go to our website to take a look at that. Each resident does have a mentor within the program. So you may have a policy or procedure where you meet up with core faculty in your department, in your program. We have resident-specific wellness programs, and each of our programs do a great job at creating these wellness opportunities for our residents. We have resident social functions. Most recently, your colleagues have really fought for, over the past few years, some enhancement of our cafeteria options. So that's been improved. And so, we also have ComPsych. ComPsych is a resource that is available 24/7 for any urgent and emergent issues that might occur. This is all anonymous. You can maintain your anonymity and still get the care that you need. So this is our wellness response algorithm, and it was developed last year. And basically, this is for guidance and assistance for a resident that might be having a mental health issue, where they might be at imminent risk to themselves or to others. And so we have this pathway. If a resident is in any kind of imminent risk, and then the person that is with that resident will stay with the resident. They'll get some emergency contact information, and then let them know that there are Counseling services that are available. Our wellness response team at the university will assist us in assisting getting our resident to a place that they need that's safe. After hours, there are community resources well known as COPES here in Tulsa, and then in Tahlequah, where our other site is. There's Grand Lake Mental Health. So this is something that I think you should put up in your resident didactic areas, or put it on your phone. It is an algorithm that we use. The other, if the resident is not at risk to themselves or others, but showing, moderate, severe signs of distress, we have this algorithm that essentially will get the resident to the care that they need. So please take time in your didactics here in the next couple of weeks to review this. Please let us know if you have any questions. The wellness response team is always available to assist our residents in any way, and talk to your fellow residents, your senior residents, your faculty, your program director, and we will assist you with this. Again, there's ComPsych, which is available 24/7. Community Care Employee Assistance Program, that is another number that you can call, and then the local number for COPES is there. So let's talk about, this is kind of the last focus area under professionalism. CLER and ACGME really wants to focus on these areas of honesty, integrity, and mistreatment. They place quite a bit of emphasis on the ethical use of the electronic health record. Along those lines, we want to talk about our professional code of conduct and any education in conflict of interest declaration. And in addressing professionalism, our patients have the opportunity to let us know how we're doing in terms of their expectations of professional care. So, Crucial Conversations is a very interactive program. It's 16 hours. And it involves education of our residents and fellows and nurse managers and hospital staff. And basically this training is devised to address those high-risk situations where maintaining a degree of calm is going to be important when there may be some emotional triggers during these high-risk events, and the goal is to clarify and the communication so that the right things happen for the interest of patient safety. You have a Chief's Resident Council, and each one of your programs have a representation on that council. Please use your council as a liaison to any concerns that you might have. And they meet on a monthly basis, and they also disseminate quite a bit of information from our ACGME office. Under professionalism remediation, so there may be unfortunate instances where there may be some lapses of professionalism. And so we do have a remediation process that assists our residents through that process. CLER focuses, of course, on scientific integrity. So in your research and your scientific endeavors, whether it be quality improvement, or clinical research, just an emphasis on, there should be insulation from any bias or fabrication, plagiarism. And so just be cognizant of the ethical approaches with regard to scientific integrity. And financial conflicts of interest. So they really would like us to educate you all on the conflicts of interest in medicine. And this kind of goes both ways. As an attending physician, as if we have any stock ownership, or if we do any consulting or have any intellectual property, and we are training residents to, in this realm, we should disclose to our residents that we have some degree of financial conflict of interest, whether that be at the beginning of a rotation, or perhaps an attending is giving a grand rounds presentation or a presentation in general. They should disclose whether or not they have a financial conflict of interest. And so just in contrast, there are non-financial conflicts of interest, so that you know what they are. There are academic conflicts of interest. There are conflicts of conscience, and there's personal conflicts of interest as well. So EHR copy and paste. Okay, so CLER and ACGME are really big on this, and there's a good reason why. I think historically, perhaps we have used the copying and pasting. We've gone in as a resident, and we've looked at a medical student's note, and we've kind of copied and pasted and moved it forward to the next day. And they really do frown upon this because inaccurate information can be propagated throughout that record year over year. And so it can really cloud the judgment of any physicians that are handling the record and that patient. So also the copying and pasting, I know that you've all seen this because I've seen this, is that copying and pasting really makes it easy to have these long, drawn out, disjointed 20-page progress notes. Okay, so it can really be quite distracting from what has occurred in the previous 24 hours. So make sure that your progress notes don't have these rambling notes that just go on, and try to avoid the copying and paste phenomenon. And ACGME and CLER are very specific with regard to this training. They really want to know that your attribution of what has happened to that patient is your attribution. That's your history in the physical and your physical examination that's documented. And here's a kind of an example of what has happened previously. This is a real case where the patient allegedly had a history of a quote PE. This was interpreted by clinicians that were looking at the record as a pulmonary embolism. This patient went on and had an unnecessary CT to rule out a suspected recurrence of the pulmonary embolus. But really, the quote PE was used in the electronic note to indicate that the patient had a physical exam, not a PE. So here you can see the potential of risk, where this patient may have had a contrast reaction, or they could have had a borderline GFR and had a contrast-induced renal insult that plummeted their GFR. So we have to be careful with copy and paste, because there are some inherent hazards that can occur. So misconduct is, these are behaviors where a reasonable person would know that the behavior is wrong. So drug use, diversion, lying, cheating, or stealing. Your program directors, and this is when we do our CCCs, our Clinical Competence Committee reviews of each resident. We look at all the milestones, and professionalism is of course one of them. And if there is any misconduct that occurs during your training, your program directors will determine whether or not the resident should have known that the behavior was wrong. Did they have the capacity to learn from their mistake? So would they have insight or remorse for what has happened? And do they have the ability to demonstrate proper conduct moving forward? So can they learn from their mistake and move forward? The program directors will also weigh out other factors, such as just how serious the conduct was. Did it have any kind of impact or harm? Does it have the potential of future harm should that behavior occur? So all these are taken into consideration with regard to misconduct. And here is a Venn diagram that talks about, that kind of illustrates professionalism being of course at its core. There may be instances where we have the opportunity to educate our residents when there are some gaps in professionalism. We believe that the resident will learn from it, that they have some degree of insight or remorse, that it's a well-intentioned mistake and perhaps a miscommunication. And it's possible that you may also have been led astray by someone who should know better. On the misconduct side, we will assess whether or not a reasonable non-physician would act in that way. Is there a lack of insight or lack of remorse? Is there a lack of good intention in your conduct? And an assessment of whether or not we think it will likely occur again. So again, there are some thoughts there that professionalism cannot be taught. There are some thoughts that it can be taught. We believe that there's opportunities for role modeling and for education that can have an impact on professionalism. And your credibility and your reputation is valuable. And so how you conduct yourself, how your colleagues see you, how your patients see you, is vital to your success and longevity in your professions. So guard it. Aoa Code of Conduct, I think we've all seen this, but I'm sure it's nice to see these periodically. Again, under our Code of Conduct, just to highlight a few, that we appropriately manage our potential conflicts of interest. We exhibit beneficence, that we always act in the best interests of our patient, placing our patient's needs first, that we treat our patients with dignity and truthfulness and honesty. As you can see, all of those clear highlights are in our Code of Conduct. We also have the AOA Pledge of Commitment that focuses on displaying integrity and professionalism throughout my career, just to highlight a few things there. And then HCAPS, this is another area, I alluded to this earlier, with regard to our patients' perception of how we're doing, of how we're interacting with them. So each year, every hospital will send out 300 questionnaires, and it goes straight to the patient. And And these are publicly reported, so our patients will grade us on how we're doing in various aspects of care. And there are 27 questions. 3 of those questions actually are about how we as physicians, residents, fellows, how we are perceived by our patients in terms of our professionalism. And it asks them about how we interact with regard to respect and our listening skills and our communication abilities. And so here are the questions that go to our patients. How often did doctors treat you with courtesy and respect? How often did doctors listen carefully to you? And how often did your doctors explain things in a way you could understand? So we are not only graded on these, but our hospitals are actually reimbursed. And so the higher our score, the higher our reimbursement. But know that the patient does have a voice in terms of their perception of their experience with us. So in essence, these CLER visits can be a pretty powerful tool. And I think that, that we need to collaborate with our hospital to increase our patient safety and quality improvement initiatives. And hopefully our hospitals will see the GME and our residents and our fellows as first line eyes on opportunities here. So I'll leave you with this. Without safety, there is no quality. Without quality, there is no safety. And without quality and safety, there's little opportunity for improvement in patient care. So you are all vital to the success of our programs and the impact that we have on our patients. So these are your administrative CLER contacts here. Lisa Cummins is our CLER manager, and many of you know her, and Melissa Bailey as well. She is our executive assistant, and so please avail yourself to us. We are happy to help you in any way. We have a CLER website that can be accessed, and that is at, if you go to the OSU CHS website, we have a CLER web page that has all of this information. So as soon as we know when our CLER visit is, I will make contact with everyone again, and we will get ready for our visit. So thank you for your time. I'm happy to entertain any questions that you might have, and I'm sorry I went over by a few minutes. Okay, hearing none. I hope you have a great day and a great week. Bye for now.